Welcome back, students, to Decode Healthcare with Harshal. I'm your lead instructor. Before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in part 137, we covered pediatric and neonatal DRGs, looking really closely at high acuity care. Today, in part 138, we're unpacking the massive financial and compliance stakes that sit quietly behind adult inpatient admissions. You know, the financial health of our entire healthcare system relies on the absolute precision of these codes. So let's decode exactly how clinical notes transform into a multi-thousand-dollar reimbursement claim.
Here is our roadmap for today. 1. Decoding the IPDRG system. 2. The principal diagnosis rule. 3. POA flags and financial penalties. 4. Ethical CDI query practices. 5. Structuring ICD-10 PCS codes. And finally, 6. Submitting the final claim.
Section 1. Decoding the IPDRG system, the foundation of hospital revenue.
Okay, let's dive into this. Under the Inpatient Prospective Payment System, or IPPS, Medicare and other payers don't just pay a hospital a la carte for every single cotton swab or aspirin used during a stay. Instead, the payment is prospective. It's a fixed rate calculated before the patient is even discharged, and it's based on the Assigned Diagnosis-Related Group, or DRG. Think of the DRG as a way to group together hospital cases that are clinically similar and expected to consume a similar amount of hospital resources. It is literally the single most important factor determining the hospital's reimbursement for that entire episode of care.
And this brilliantly illustrates exactly where this fits in. Look at stage 4 of the revenue cycle management workflow, the IPDRG phase. It sits perfectly nestled right between the patient's discharge and the actual billing process. This is where medical coders take the clinical documentation from the hospital stay, assign the diagnosis and procedure codes, and feed them into DRG grouper software to generate that final payment group.
To put that into perspective, take a look at this table. If a patient is admitted for simple pneumonia and the coder successfully captures a documented secondary diagnosis of COPD, which counts as a comorbidity or complication, a CC, the DRG payment is $8,500. But if the documentation is kind of vague or the coder misses that COPD, the DRG drops to a lower tier without a CC, and the payment plummets to $6,200. That is a $2,300 loss for the exact same patient care, purely due to one missed code. Wild, right?
Section 2. The Principal Diagnosis Rule. Finding the true cause.
Now, what's really interesting about this slide is it draws a hard line between why a patient comes to the hospital and what the hospital actually treats. The primary reason for admission might be severe chest pain. That's the symptom on day 1. But the principal diagnosis is defined as the condition established after study to be chiefly responsible for occasioning the admission. So if tests confirm an acute myocardial infarction, a heart attack, that is the principal diagnosis. If the coder accidentally uses chest pain as the principal diagnosis, the DRG would be completely incorrect and drastically underpaid.
Because the principal diagnosis drives the entire DRG category, sequencing rules are strictly regulated. For example, if a patient has sepsis present on admission, and that's why they were admitted, the sepsis code must be sequenced first. On the flip side, if a complication arises from the care provided, like a postoperative infection, that is strictly a secondary diagnosis.
Section 3. POA flags and financial penalties, when timing matters. Let's move on and see how this builds into one of the most heavily scrutinized areas of modern healthcare compliance, present on admission, or POA indicators. Every single inpatient diagnosis on a claim requires a POA flag. Y means yes, it was present when the patient walked through the doors. N means no, it developed during the stay. U means there isn't enough documentation to tell. And W means the provider clinically cannot determine it.
So the crucial point is, what happens to a hospital's payment if a severe condition, like deep vein thrombosis or sepsis, develops after the patient is already admitted?
Well, here's how that plays out. Because the condition develops post-admission, the coder must flag the POA as N. This immediately turns the condition into a hospital-acquired condition, or HAC. Under Medicare's Deficit Reduction Act policy, that condition is entirely stripped of its ability to increase the DRG payout tier. Even if it's a major complication, the payment drops, and the hospital faces quality reviews and bundled payment penalties. It's a huge deal financially.
Section 4. Ethical CDI query practices, bridging the documentation gap.
With stakes this high, clinical documentation absolutely must be flawless. That's where clinical documentation integrity, or CDI, specialists come in.
When a doctor's notes are ambiguous, they send a query, but there are very strict ethics governing how they do this. What you see here is a blatantly non-compliant leading query. By asking, "Do you agree the patient has septic shock?" the query is literally feeding the provider the diagnosis. This is a massive legal risk. It can trigger government audits for unethical upcoding and fraud under the False Claims Act. You definitely don't want that.
In contrast, a compliant query is evidence-based and open-ended. It provides the clinical indicators and simply asks the physician to clarify the patient's status from a multiple-choice list. That list includes varying severities, an other option, and critically, a no-change option. It doesn't force a high-paying diagnosis, it simply asks for the clinical truth.
In this structural breakdown, notice how a compliant query always includes patient information, the specific clinical context, like lab results, an excerpt of the ambiguous documentation, and a non-leading question. This protects the hospital's revenue integrity while ensuring the case mix index accurately reflects the true clinical complexity of their patients.
Section 5. Structuring ICD-10 PCS codes, the procedural blueprint.
Now that we've covered the diagnostic side, we really need to look at the surgical procedures that often drive these hospital stays using the ICD-10 PCS system. Every single ICD-10 PCS code is exactly 7 characters long. Not 6, not 8, exactly 7. It is a highly structured alphanumeric blueprint where every single character represents a specific piece of the procedural narrative.
Let's break down a common open appendectomy, coded as 0D-TJ0Z. The 0 tells us it's a medical and surgical section. The D identifies the gastrointestinal body system. The T is the root operation, in this case, resection, meaning the removal of all of a body part. J specifies the appendix. The 0 indicates an open approach, and the 2 Z's at the end mean no extra devices or qualifiers were used. Coders literally build these codes character by character from tables, based entirely on the operative report. The precision required here is staggering, especially with root operations. Take wound debridement, for example. If a surgeon uses a scalpel to cut away necrotic tissue, that is an excisional debridement. But if they use an ultra-high-pressure water jet or mechanical scrubbing to wash away the tissue, that's a non-excisional debridement. The difference in the resulting 7-character code and the subsequent DRG payment is profound.
Section 6. Submitting the final claim. Translating care to reimbursement.
So we have our principal diagnosis, our POA flags, our ethical queries, and our 7-character PCS codes. It all consolidates right here, on the UB04 form or its electronic equivalent, the 837I. On the left side, you see the revenue lines representing room and board, pharmacy, and operating room services. On the right, down at the bottom, you can see exactly where those hard-earned ICD-10-CM diagnosis codes and the PCS procedure code finally land before being submitted to the insurance payer.
This final technological relay race ensures clean data routing. The codes are assigned in the encoder, fed into the DRG grouper to calculate the relative weight, mapped onto the UB04 claim, put through a rigorous pre-bill validation to catch any missing POA indicators or illogical code combinations, and finally submitted for payment posting. We've seen how a single missed comorbidity can cost thousands of dollars on just one patient. Multiply that by thousands of admissions a year, and you realize that medical coders and CDI specialists are the true financial guardians of our healthcare system. How could a single misplaced character or a poorly worded query impact the survival of your local hospital? Keep that immense responsibility in mind. Next time, in Part 139, we'll explore international DRG systems and global inpatient payment frameworks. Now, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in the next lesson.